Good afternoon, everyone. I'll let everyone chime back in. I'm going to get us started. Hoping everyone enjoyed the opening session and the discussion around workforce strategies or strategic session planning. I'm excited to welcome you all to our first full topic session on telehealth in the remote environment, really looking at considerations around the post-pandemic workforce. So I'm pleased to welcome today's speakers. You have here Ms. Molly Evans, who's an attorney with Feldesman Tucker, as well as Dr. Kemi Alli, who's the CEO at Henry J. Austin Community Health Center up in Trenton, New Jersey, not too far away from here. So telehealth and the new remote work opportunities are changing the way in which health centers operate, as we know very well over the past 12 months. So in addition to remote work legal opportunity or considerations, having staff who are no longer sharing physical spaces changes the workforce dynamic tremendously. So given the benefits of remote work for employees, many health centers will be adopting hybrid work environments. So in this session, you'll hear about legal considerations for remote work from Ms. Evans, as well as strategies to support team cohesion when staff are no longer co-located in the same space or same facility on the clock. And you'll hear that from Dr. Alli. So a little bit more about Molly. Molly is a partner with the Feldesman Tucker Leifer Fidell firm in the firm's health law practice group. She advises health centers on management of clinical, employment, and work-related risk, with particular focus on professional liability, FTCA or Federal Tort Claims Act, and HIPAA matters. From her experiences as both a private attorney and in-house counsel, Ms. Evans knows the importance of managing liability and those risk issues with mission-driven organizations like health centers. She counsels healthcare entities such as community health centers on fraud and abuse, patient safety, privacy and confidentiality, risk management matters. She also advises clients on legal issues related to corporate transactions, mergers and acquisitions, as well as affiliations and joint ventures. So we're excited to have Molly join us for this presentation. And secondly, Dr. Kemi Alli, CEO at Henry J. Austin Health Center in Trenton, New Jersey, a role she's taken on in 2015. She was previously the Chief Medical Officer at Henry J. Austin, so she's been there close to 20 years. So excited to have some amazing healthcare leaders, health center leaders on our team. She has completed her residency at Robert Wood Johnson Medical School in Pediatrics in '98. She serves on the board for the New Jersey PCA, or Primary Care Association, New Jersey Healthcare Quality Institute, and the Thomas Edison State University. So she's devoted to the Trenton community tremendously and works with organizations like Trenton Health Team, as also taking part in the annual Anchor house ride, riding almost over 500 miles in 1 week. That's amazing, to raise funds and support for those children in the community that need it most. So, and keeping in mind, I will be moderating today's session, and about the last 10 minutes of the session, I will moderate particularly any questions that you guys have. So please feel free to pose any questions in the chat, and I'll try to make sure I collect them throughout the presentation so that I can address those with our speakers if we have time. So in the last 10 minutes of the presentation, we'll get to those. So with that being said, I'm going to hand things over to Molly to get us started, and I'm going to stop sharing and let you take over, Molly.
Hey, thank you so much, Brandon. And thanks, everyone. I'm so happy to be here with you. I recognize a lot of familiar names and faces who I'm always happy to see, and some new names and faces too. So I appreciate the introduction. I'm excited to hear Dr. Alli's presentation as well. And I'm going to just walk through for about the next 20 minutes what we see at our office at Feldesman Tucker around some of the considerations that are starting to come up for you in your roles in the health center, and trying to figure out how you're going to navigate this post-pandemic workforce experience and or experiment, I think, in terms of the ability for your staff to stay at home on a full-time basis in a hybrid methodology, or to the extent that you've determined in your health center, which in a lot of health centers that we work with, that your staff is going to be full-time on site. So because of the nature of today's conference and this session, I am not going to spend time talking about the billing considerations around the flexibilities that were extended during the pandemic for billing in Medicaid, Medicare, and then in other billing flexibilities. But I would just like to caution at the outset that it's time to start focusing on when your given state is ending their public health emergency, because that time is coming, and it seems to be different in every state, and whether or not there will be extensions or not is going to be important, but that's going to control and drive a lot of the flexibilities that you may have had in your on the billing side of telehealth, and frankly on the licensure side. I'll talk about that a little bit, but I just wanted to flag that since I won't be talking about that today because of the emphasis of today's presentation on the workforce. So the risks I've identified for today's presentation in terms of the considerations that you want to be thinking of when you have a remote workforce or have members of your workforce working remotely on an ongoing basis post-pandemic are really in 4 categories. I'm sure if we had 2 days together, we could come up with 5 more categories that we would want to focus the risk on, but I've tried to highlight these as these are the ones, at least in our office, that we see coming up the most for health centers. So, and then frankly, some that maybe should be coming up, but that are not top of mind for most of us as we are responding in a 14-month fire drill, as it were. Things like corporate risk to the health center organization from a corporate perspective in terms of the rules of being a nonprofit in your jurisdictions and potentially other jurisdictions, professional risk to your providers in providing care via telehealth, and making sure that you are identifying and capturing those risks and handling them. Employment-related risk, which really feels like the bulk of what most organizations, healthcare, health center or not, are dealing with. And I think that's why there are a lot more resources out in the world for you to explore that have already been developed, because that extends beyond the health center environment to all sorts of workforces. And then finally, IT related risk. Again, there's probably a lot more resource development there than in some of these others, particularly around the professional risk when we talk about things like FTCA. So the employment risk, because of the nature of this presentation, I really hope to help you with issue spotting rather than really spending a lot of time delving into each of these. But some of the considerations in thinking through, particularly if you stood remote work up sort of overnight, like most of us did, are what are going to be the ongoing expectations around compensation and scheduling hours, particularly for that non-exempt staff. So if you have non-exempt staff, how are you monitoring overtime? How are you capturing break time? How are you ensuring that you're not running afoul of labor laws, wage and hour laws with your non-exempt staff members? And that can certainly be challenging to do when staff is working from home, but thinking about that as one of the largest employment related risks associated with really extending this, this concept of remote work beyond the pandemic. Adjusting compensation if you find that you have employees that you're permitting to work remotely from a place where the cost of living is lower. So if you are in an urban center and you are allowing staff members to work from home, and again, for health centers, I'm not sure how much this comes up in terms of if you're going to be allowing members of the staff to work full-time from home, but to the extent you are, is there going to be pay differentials to the extent that you have staff members that have to live within an urban center rather than those that can live outside and have a lower cost of living? Another thing that has come up and maybe is a problem that you've solved for, or maybe you've solved for it sort of in the sort of Band-Aid way of doing it in terms of identifying how you are going to handle expenses associated with home offices or remote workspaces in terms of allowing employees to purchase equipment, things like printers and scanners, computer equipment. Is there a technology allowance that you're using that employees have to facilitate what they're doing in a home office, or how is the health center handling that? And is there enough formalization of that so that you don't find yourself in a situation where you are treating people differently on how you're supporting their remote work based on either their job level or their status in the organization, their gender, things like that. Another thing that and I think these two work in tandem, that a lot of organizations in sort of exploring this remote work concept have identified is the lack of training. And I think Dr. Alli can probably give us some guidance on how Henry J. Austin has approached this, perhaps how the staff members are trained, how you have confidence that the training that they've received is acceptable for the standards of your health center, and how are you evaluating staff members when they are remote? How do you know how the work's going if you don't have objective identifiers in terms of patients seen, et cetera? The work is harder to identify the successful nature of it. How do you identify that, and how are you evaluating staff members remotely? Does that sort of, have you paused your performance evaluation system, or are you conducting it remotely, et cetera? And then finally, how are those separations being conducted when you have someone that is full-time remote? Again, I think that we've all sort of had to do the best we could in the last 14 months in addressing these issues, but to the extent that the health center is going to find itself with a remote work option over time, these are some of the considerations, and they really come again from the Fair Labor Standards Act in terms of wage and hour issues, all of the EEOC related protections. So discrimination laws around protected classes like sex, like disability, like the other sorts of discrimination questions that can come up when you are going to make decisions that seem more favorable to one group versus another. So I leave this here, and again, I think that there are a lot of resources, particularly the Society for Human Resources Management, a national association, if you're not familiar with it, has a lot of good resources around developing remote work and telework policies that you might find helpful. On the corporate risk side, I think where this comes up, and this to me seems like something that may not be top of mind to health centers that are not accustomed to working in multiple jurisdictions, is your remote work capability creating an environment where you actually are going to be required as an organization, as a health center, to file a registration in another state? So an example I have here is where you have a health center located in Ohio who has 35 of 50 administrative staff that live in Kentucky. The health center needing to figure out if they need to file as a foreign corporation doing business as Kentucky because they've reached a certain threshold. And the sort of the bad news is that every jurisdiction is going to be different in terms of how they define what you're doing, in terms of whether or not you qualify as a foreign organization doing business in their state. So you just need to be familiar with that. On the employment law side, that also shows up on the income tax piece in terms of where they're residing. The other sort of corporate risk that comes up attached to this foreign jurisdiction piece is, what are the tax implications of the health center allowing employees to work from another location? What is the threshold number of people that would put the health center into the category of having to pay taxes in another jurisdiction. I know in the pandemic, at least a lot of the health centers we work, not a lot, but some health centers we've worked with have not even been aware that staff members have moved away from their the health center's location to another jurisdiction, and that has created tax liability for the health center that they weren't aware of. So getting a handle on that is going to be a first step post-pandemic, and then again, to the extent that you allow that to happen, that you are at least making an inquiry into what your tax liability might be, and your accounting professionals should be able to help you assess that sort of risk and whether or not you have it, so that you can either handle it, file tax returns in the states if you have to, et cetera, and make sure that you don't have an issue with that. On the professional risk side, importantly to keep in mind that the FTCA program hinges on this concept of scope of employment. And in the pandemic, we see a lot of health centers shifting to a remote work methodology sort of again overnight, and not their documents not necessarily catching up. So we have seen in our office at least health centers that have employment agreements that for very good reason specified where a provider or a staff member was required to work or was permitted to work. So Molly Evans is permitted to work in sites A, B, C, and D, and that's the extent of where she works. Or she works on the mobile van and she works in sites A, B, C, and D. Most employment agreements did not specify or do not specify the fact that health centers might also have their staff members now permitted to work from home, and particularly for providers, to the extent that your employment agreements and your job descriptions are not caught up with the fact that you are permitting that work. You're creating liability for the health center and for the providers, such that you could imagine that the Office of General Counsel could say, we're not covering this because it's not in the scope of employment of the health center provider, because the health center says that provider can only work in these locations, didn't say that the provider can work from home. So we're not covering this case. We haven't seen that come up, but it is a concern that your documents don't really fully capture the program that you have now, particularly if you have a robust telehealth program that you developed over the pandemic that did not really consider the fact that your documentation was a pre-pandemic non-telehealth program situation. So making sure that all of those documents, provider agreements, employment manuals, job descriptions are caught up, and acknowledge the fact that you have staff members working remotely from home or in other remote locations that are not in the health center sites. So an easy way to fix that is to do an amendment to the employment agreement or other writing between you and the provider to acknowledge that case. The other way that this comes up is on gap insurance, to the extent that you are a health center that has gap insurance, or even if you have private malpractice insurance. On the professional risk side, really making sure that you are clear that the gap insurance policy covers telehealth services the same way that it might face-to-face in the clinic traditional healthcare services. It really is going to depend on the gap insurance policy as to whether or not it's automatically covered. Some policies are clear that they view a telehealth provision of care the same way as they would face-to-face. Others require the health center to provide notice of this new way of providing care, and either potentially increase their premium or get a rider or have some other change that has to happen in order to have coverage for that. So you want to make sure that you are in touch with your broker, reviewing your policy, making sure that you understand your specific health insurance, your specific gap insurance or other professional liability policies to ensure you have coverage on that. I didn't include in this professional risk slide the other risk that comes up, which really relates to when you have a patient that is remote and not in the jurisdiction of the health center. But I just flagged that again, that we're seeing that a lot where health centers, because of the nature of this telehealth services, they don't necessarily have an awareness of where patients are located when they're receiving care, and that can create licensure issues and professional risk for the health center as well. So just want to flag that for you as well. And then I think this is my last slide. The IT risk piece is also of a significant concern from our perspective at Feldesman Tucker, at least, just in terms of how you are issuing, using, and accessing technology, or how your staff members are in remote locations, how you are determining whether or not they are going to be permitted to use their own devices when providing services remotely, how IT security effectively is implemented, particularly when you have a lot of patient health information moving back and forth into remote locations. How are you analyzing particular vulnerabilities of your employees? And then how are you sort of bringing into the security universe of your HIPAA security plan those remote locations, which it may not have traditionally been thinking through. So I think on the IT side as well, there are resources that are out in the universe that are available for you to utilize to assess these risks. I'm happy to share them with anyone that has an interest. I have my email here, and I will pause, or I'll stop actually, so that I can turn it back over to Brandon so he can turn it over to Dr. Alli, and I'll be around for questions.
Thank you, Molly. And you know what? We only got one question, and we do have a few more minutes before we can hop it on over to Dr. Alli. So I'm actually going to ask that question. Beth put in the chat, is there a preferred language to put in the contract? That's one question. How do you handle non-competes? We usually said the site they work. So is there a preferred language to put in the contracts?
Oh, that's a great question. The interaction with the non-compete. I think that making the language more flexible in terms of that you can also assign the provider to provide services via telehealth from home would be a good language to include in the contract. I guess on the non-compete side, what you would want to figure out is, especially if you have a mileage limitation, is it only going to be, and I presume it would be miles from the health center sites. You wouldn't factor in the miles from, 10 miles from any of our sites, but not maybe 10 miles from the provider's home. I'm assuming that would be carved out of the restrictive covenant, but that's a great point. That you would, in the non-compete, also identify what the mileage restriction was, and you wouldn't count the provider's home. Great point, Beth. Thank you.
Wonderful. And we do have just a couple more minutes. So one just popped in from Karen Tepper. If a single employee relocates to another state, do we become subject to employment laws from that state? Is that a state-by-state determination?
That is unfortunately a state-by-state determination, which makes it really hard to answer the question. But another really important consideration to run down.
Great. And hey, we got a couple more minutes. So Greg just popped in the question, do you find non-competes enforceable?
So that is a state-by-state question too, in terms of how enforceable a non-compete can be. A non-compete that is reasonable in terms of mileage and length of time, so 1 year or 2 year, 10 miles, depending on the jurisdiction. Of course, in the District of Columbia, 10 miles is a lot more significant than it is in Montana. So the mileage is going to depend on where you're located in the country. But they can be enforceable in states. I know a lot of health centers struggle with whether or not to use them. And then even more so, the health centers that do use them, I don't see them enforcing them. I see them not having the bandwidth to pursue providers that are going to compete, even though they're breaching their contract. So whether they're enforceable is one question, but the other is whether or not you actually have the ability to, you have the ability, but if you have the energy, I should say, to pursue.
Is what.
Oh, and thank you.
Mhm.
All right, thank you, Molly. And
Sure.
there are a few questions that popped in, but I'll just hold on to those, and we'll save those for the tail end. And we're going to go ahead and bring in Dr. Alli and let her share her screen and get started. And again, if you have any additional questions for Molly, just post them in the chat, and I'll be saving them offline so we can field the speakers afterwards.
Thank you.
Dr. Alli?
Yes, hello everyone. So I believe someone has to stop sharing.
If you stop sharing, oh, there we go.
Excellent. Well, good afternoon, everyone. Thank you so much for this invitation to present to you today. And more than presenting, I say a discussion we can have. So I am Dr. Kemi Alli. I'm the CEO at Henry J. Austin Health Center. As described by Brandon, thank you. I've been at my health center now going on about 24 years. I'm a pediatrician by training, and I worked on the front line for the first 10 years, and then I became the CMO at the same health center. And now I'm the CEO, so have a lot of experience working in the community health center space. So this idea of team cohesion is really important to me, particularly because I did work on the front line. I do understand how important it is to have a supportive team that works together for the benefit of the patient. And as we've been talking about, the pandemic has really disrupted that. But I'll go walk you through some of the things I really think we need to be thinking about as it relates to team cohesion. So what I want to touch upon today is who we are, Henry J. Austin Health Center. Just give you that snapshot so you can put the work we do in context. Talk a little bit about where did we start, because I think that starting point is really important. Talk about why does this matter? Why does team cohesion even matter in terms of also where did we start? Why was that important? And then what do we do to build upon that team cohesion? How do we maintain it? How do we sustain it? How do we build upon that? So just a quick snapshot of Henry J. Austin. We have 4 standalone sites, the very traditional bricks and mortar sites. We have 3 sites that are located embedded within mental health institutions. So it's like a little primary care practice office within mental health institutions. We have 1 such site location that is embedded within a homeless shelter. And then we have our mobile health unit. We serve about 18,000 patients in any given year, and about 30,000 patients consider us their medical home. We have 30,000 active patients, and we generate about 70,000 visits. About 1 in 10 of our patients are homeless. About half of our patients are African American, and about 1/3 of our patients are Latino and prefer to speak in a language other than English. So again, gives you a little snapshot of our organization to put what I'm talking about today into some context. So teams. Like many of your organizations, I'm sure, teams are everything at Henry J. Austin. It's really the fabric of how we believe we should be delivering care. So we have about 15 clinical teams, and they are made up of all types of individuals within our organization. So we have a cadre of staff, over 200 employees, and then we also have AmeriCorps Vistas, we have residents, so we have our own nurse practitioner residency program, we have medical scribes, so medical scribes work with our providers, and we have students. We have pharmacy students, we have medical students, as I said, we have nurse practitioner residents, we have nurse practitioner students, so as you can see here in this diagram, all the different individuals that are coming together to form our teams to envelope and sort of surround our patient. So you can imagine team cohesion is really, really important within our organization. so that things work effectively, efficiently, and we can provide quality care to our patients. So where did we start? And I'd say right at the very beginning. So in the midst of the pandemic, we actually took some time to go back to our vision statement, to go back to our mission statement, to go back to our values, because we realized the pandemic changed things, and we wanted to make sure that our vision, mission, and value statements are still aligned even in the pandemic world, and then more importantly, in that post-pandemic world. So as Molly said, really beginning to think about, okay, how do we need to change our policies, our procedures, our vision statement, our mission statement, so it incorporates the hybrid world that we're going to be in for the foreseeable future. So one of the things we did is we changed our mission statement. And we said we want to work with our community partners, with our exceptional teams, to provide trauma-informed holistic care to maximize individuals' strengths and abilities to achieve optimal health and well-being. So I highlighted there that exceptional team, and that was important to us. And we put it in the mission statement so that it is now intentional that we need to create objectives, goals, initiatives in order to have those exceptional teams, even in the pandemic and post-pandemic. And so therefore, those initiatives are now built into our strategic plan, and I'm gonna go over a few of them with you. So here we have the framework that builds on those strategic initiatives that we talked about. So again, where did we start? I like the idea of a framework, because otherwise it's so hard to grab your hands around this idea of team cohesion or the team engagement, wellness. It's really hard to solidify that. And so the framework we use that I really like is from the Institute for Healthcare Improvement, and it is called Joy in the Workplace. And when I saw this, I was like, wow, this is exactly what we want. We want, at the center of this, you will see it says, we want happy, healthy, productive people. We want happy, healthy, productive staff. And so I was just enthralled that, wow, there's an actual framework to make this happen. And as you can see here, the heart of that happy, healthy, productive people is surrounded by 9 pillars to make this happen, 9 pillars that make up this framework. And one of them is camaraderie and teamwork, or what we call team cohesion. So it is, how do you have social cohesion, productive teams, shared understanding, and trusting relationships. The other thing that's really interesting when you look at this framework is it has an outer layer there called senior leaders, and then it builds on to managers and core leaders, and then you get to the individuals within the organization. So there's a lot going on here. And so how did we tackle this? And there's the saying, you tackle it one bite at a time. So how do you eat an elephant? One bite at a time. And so we took pieces from each of these pillars and we started working on them. Whether it was, how do you create meaning and purpose? We started a wellness program, but also this idea of building camaraderie, building teamwork, and another synonym for that is team cohesion. How do you build team cohesion? So as I said, it was interesting that the outer layer of this framework was starting with the senior leaders. And what we realized is that our senior leaders, and there's about 18 of us all together. If you look at our organizational structure, we have chiefs, and then under our chiefs are our directors, and then we have some supervisors, managers, and staff. And we realized that outer core of senior leaders, we were not cohesive. The first time we met to talk about this, we realized there was some tension and there were some things we needed to work on as senior leaders. So in the IHI model, this joy in the workplace model, one of the first things it says you can do as you're building that team cohesion and starting to work together is identify what's called the pebbles in your shoes. So what are the things that just seem to nag you? What are the things that are bothering you from that joy in the workplace? So as senior leaders, we got together and we identified those pebbles. And we identified that some of the core things that were bothering the senior leaders, the pebbles in the shoes of the senior leaders, was the culture within our organization. And we wanted to improve our organizational communication. And this is really important, I think, because we happen to have started this work pre-pandemic. But if you haven't started this work, you can do it right now, because I think it's still the foundation of this idea of team cohesion. And so we realized that we really didn't have a culture. And so we wanted team cohesion, we wanted a better workplace, but we really had never defined our culture. And that really is the starting point of building team cohesion, of building that camaraderie as we saw it and we analyzed and we discussed. We have to, as senior leaders, set the tone. What do we want the culture of our organization to be? And so we started on that journey of how do we shape our culture? How do we define it, number one? What do we want it to be? And then how do we go about making those changes? And as anyone knows, changing the culture of an organization is a marathon. You know, going back to the analogy of the pebble in the shoe, you can't run a marathon with pebbles in your shoes if you've ever tried. And so you have to remove those pebbles. And then this idea of changing the culture, it's a marathon. It's not something you do in 30 days or 60 days or 90 days. This really takes years of work. And then also the idea of improving that organizational communication is key to team understanding, to team cohesion. They have to be able to have effective communication. And I'll touch upon that a bit more too. So a little bit more about why we started with our leaders. We believe that our leaders set the tone and culture, as I just described. Your culture is set by the organizational leaders. And we believe that our leaders needed to have that buy-in in order for us to have team cohesion within the departments, within those individual teams. If you have a director, if you have a manager, if you have a chief, or some people call those vice presidents, that have not bought into this idea of team cohesion, you can imagine you're going to have really sporadic buy-in from everyone that reports to them. So having that buy-in from the senior leaders, we thought was really critical to setting the stage for how we wanted to have team cohesion within our organization and how we wanted to change that culture. We also understood that, having champions within a team, like, we often have a champion provider or a champion nurse, or maybe a champion within our administrative departments, and they are great. But when you really have a leader, someone that has the authority to affect and make change, when a leader is a champion, then amazing things happen, right? Because now you've got someone who not only has bought in, who not only is championing in this work, they now have the authority to make those changes that you want to see. And so that's a great combination. So we felt it, again, really important to start with the leaders. Not only that, we understand our leaders lead by example, but not only that, we could give our leaders the tools and the skills to build that team cohesion. So we've taken the time to meet with our senior leaders so that they really can model the team cohesion that we want our teams to have. And we give them the tools, we give them the skills, we give them the resources so that they can foster that team cohesion within their departments, within their individual teams. And so again, we give our leaders the tools to be actively engaged with building that team cohesion. That was really important as we thought about all the individuals, teams that are scattered throughout our organization, giving them the tools so that they can really make the changes we want to see. So again, why start with leaders? As you're looking at this team cohesion, and I mentioned this communication, and it was interesting, as I said, because that was one of the pebbles in our shoes. We did not have effective organizational communication. And the more we understood this idea of team camaraderie, team cohesion, we began to understand just how important communication is to that. And in this journey of understanding effective communication, we came upon this work of trust and how trust is important for communication and how communication is important for team cohesion. So it led us on this journey of the 5 dysfunctions as a team. How do you really have a functional team? And part of having a functional team is really those team members have to trust each other so that they can have effective communication, and therefore you can have effective team cohesion. And this idea of trust and communication played out even to a greater extent when we were working remotely, when we were in this pandemic environment. And as we go on to a hybrid model, you can imagine it's going to be even more important in terms of that effective communication, in terms of that trust building to have an effective team. And, you know, one of the things as we look at this trust is this is one of the pearls we might have learned in our work of building team cohesion is this idea of vulnerability. And when we first read about this, and it's part of this work of the 5 dysfunctions of the team, building that functional team, beginning to understand all the different roles, the different ways that individuals function within a team or work within a team, that vulnerability is really important. And without that, you can't have trust. And without trust, you can't have communication, or you can't have effective communication. And without effective communication, you really can't have true team cohesion. And this journey has been a really interesting one, you know, starting with this idea of how are you vulnerable in a team? How do you therefore trust within a team? And so as we started this work, one of the things we realized early on that we really needed someone to help us with building this team cohesion. So we hired a professional to help facilitate our team building practices. And this individual works remotely, and we are now meeting once every 3 weeks. And we meet for about 2 hours in what we call our joy meetings, so that we can learn the skills to build that team cohesion. And we've been doing it remotely for the last 15 months or so. Again, meeting 2 hours every 3 weeks with a professional facilitator, helping us understand how do we do this work? How do we engage each other? How do we trust each other? How are we vulnerable? And then how do we model that? Because that's how you change the culture of the organization. So again, the things we learn, we then put into practice with everyone that reports to us. And that's how you develop that team cohesion within the teams. And that's how you build upon, and that's how you change that culture. We also do things, we meet once a month. Every Friday, we have happy hour Fridays. We also do this remotely. Now that it's summertime and we happen to be in New Jersey and the rates of infection are lowering, we'll probably be doing some things outside where it's safe. But for the last 15 months, we did our happy hours remotely. We took time on once a month on a Friday. We gave DoorDash gift cards to our directors and staff. And the only rule we had was during that time, you can't talk about work. And again, the idea was we modeled the behavior that we want our directors, that we wanted our chiefs to have with their teams. And then their teams could go out and do the same things. We do twice a year, we do a leadership retreat. We do it 2 days, we do it offsite. And it just so happens our next retreat is tomorrow and Friday. And again, during the pandemic, we did our retreats virtually when it was unsafe to gather. Our retreat to tomorrow and Friday will actually be in person. It will be so funny. It will be the first time we're coming together in person since the pandemic began. So it's really going to be exciting for us. It will be outdoors and it's lovely weather, so that's good. But we've been doing 2-day offsite leadership retreats for the last 3 years now. Again, with this idea of really giving our senior leaders the tools and the skills so that they can change the culture, so that they can build that team cohesion. It's just one of the things, if you remember that model of the 9 pillars, really embodying our directors and chiefs with the skill sets that they need. Again, we want our leaders to model the behavior we want to see within our organization. We want our leaders to model team cohesion so that it really does become institutionalized. It really does become part of the culture of our organization. And reiterating just how important it is to give them the tools, to give them the skills so that we can build upon that. One of the tools that we've been working with, another tip here, is a program called Miro, M-I-R-O. It's really a lot of fun. People can work simultaneously on it. So when we were face-to-face and we were doing an offsite retreat, for example, we do a lot of vision boards and thought boards, and we'd get up and we'd write things out. We'd use the sticky notes and we'd put things on the wall. Well, when you're virtual, how do you do that? And so Miro is actually a way to do that. They have virtual sticky pads, and teams can, at the same time, people can put things up and you can see it real time. So it's really a fun tool to use. One of the skill sets then that we taught our leaders how to do, then they could then share that with their team. Join the workplace orientation, for example. So how do you, again, institutionalize this? How do you change the culture? So now, as our new chiefs, directors, managers come on board, they have an orientation around join the workplace. They have an orientation around those 9 pillars and the framework that we think is important for our chiefs, directors, managers, our senior leaders to have, because we understand how important this is for the rest of the organization, for all the staff that will be reporting to these new leaders. So on that, I thank you for your time. I thank you again for this invitation, and I welcome any questions.
All right, thank you again, Dr. Alli. I always say it's great working, certainly working in NACHC, it's always great to have our health center leaders kind of provide their perspective, and certainly the work that they're doing on the ground is just always impressive. We've gotten several questions, and I'll do my best in trying to parse out so that we have enough time for each of our speakers to answer them. So what we'll do is there are a couple from for Molly, and I will just go through those first, just a couple of those, and then I'll jump over to some for Dr. Alli. How about that?
Okay.
And again, everyone, keep those questions coming. All right. So Molly, there was a couple questions for you. Can a provider see patients while traveling or on vacation in another state?
Can the provider see patients while traveling or in another state? So I'm assuming, I saw that question from Dr. Hawk. I'm assuming that is the provider is the one on vacation or traveling. Is that how we're interpreting it? Mm-hmm. Yes. So for the most part, yes, from a licensure perspective, the location of the patient is what matters. So presumably in that case, the provider is licensed in Massachusetts, the patient is in Massachusetts, the provider is in Vermont for vacation. The provider from a licensure perspective, can see the patient. Now, of course, that doesn't answer the other questions we would have around billing, around how you're going to operationalize that from a telehealth perspective, but from a licensure perspective, that should not be an issue.
Great. And one more question for you, Molly, and I'll hop over to Dr. Alli. Can we state that employees must work within a certain distance of our sites, or simply state that the employee may be required to work on site on occasion?
That's a great question. I think that you're going to want to look at your the expectations, but you could certainly set expectations around their availability. Now, if your jurisdiction has a anti-discrimination law about the place of residence, which it can, you want to be careful around saying you have to live within X, Y, or Z miles. If the person is able to get to the health center in a particular amount of time, I think having the hours might be more important. The hours that you need, it might be a better way to go about it. The hours that the person needs to be available in the health center.
Great.
Rather than dictating the location. Sorry.
Great. No worries. Thank you, Molly. I'm actually going to throw these last two questions in there for you. One is regarding someone moving to another state. Typically, if an employee has been in a state for 30 days or more, whether they move there permanently or just for a period of time, you need to look at the state laws. So I guess that's just a statement, I guess.
Great point.
Yeah, definitely. And the last one for you is I've heard some organizations no longer use provider employment agreements. Your advisement or warnings either way?
I definitely see that in our practice too. I think that that we had most health centers using employment agreements probably 10 years ago, because there was an impression from HRSA that you needed to have employment agreements for providers. That is no longer the current thinking. So I know some health centers have moved away from it. I think that the benefit of moving away from it is that if you're in an employment at will state, it makes it easier. The problem, which is the other side of that coin, is that if you want to enforce notice periods for termination, if you want to make it clear what is acceptable and not by contract, rather than having sort of a difference of opinion about what is considered acceptable in the health center, that the employment agreement makes it easier to control. Also, you can have a termination without cause provision that allows you to separate without getting into a lot of employment disputes. So I think that most health centers that I work with, at least, are using an employment agreement for provider staff and maybe C-suite. I don't see them changing that, but there's not a requirement from the HRSA perspective. I see there's a question. I know that I don't want to take Dr. Alli's time, so I'll stop, and then if there's extra time, we can get back to it.
Sure. Thank you, Molly. Appreciate that. Dr. Alli, there's a handful of questions for you, and I'm going to really start with the first one. Courtney Wolford mentioned, I would like to learn more, or like more information on how you all do your offsite leadership retreats and who assisted with your strategic planning.
So our first strategic plan, we did it internally. we are now in the process of updating or revising our strategic plan. It's due to end this year, so we're going to be working on that this summer. And that's one of the things we're going to be working on tomorrow is our strategic planning. And we're going to start. We use 2 consultants, so anyone feel free to email me, and I'll give you the name of the 2 consultants we've used at various times. I like both of them. And then our senior staff retreats, really we use it, we try to plan them, again, around something like strategic planning. We do it when it's before we do our annual budget, so we'll do budget reviews. And then really the rest of the time, it really is this idea of, how are we being a better team? How are we working better together? And so it is this idea of team cohesion, team building, team trust. And you think this idea of people working together, they don't necessarily trust each other. And you can have people working side by side for years and have never effectively communicated. And so it really has been a journey for us.
So true. Isari has asked a really good question. How does your team measure the progress your team is making in this space, as well as the impact? And if you survey staff, could you share what type of questions you ask?
Yeah, so in particular, we, among our senior leaders, there's a survey in the disc about team and where you fall on the scale of how cohesive your team is. So we use that. We did one last year, and that's where I was very surprised where we fell. And actually, one of the things we'll probably do tomorrow is a year look back. And so we'll do the same survey again and see if we've moved the needle and see if we've had an impact. For the rest of the organization, we're in the process now of looking at what kind of engagement survey tool we want to use for all of the staff.
Great. I have a few more minutes, and I do want to pose Julie's question. What was the most challenging for you and your team to overcome in building team cohesion, and what was most rewarding or surprising about that?
I think both are the same, actually. It's this idea, and that's why I pointed it out in the presentation, this idea of vulnerability, that it was surprising that was needed in order to have trust, that you have to be open, you have to be willing to be somewhat vulnerable. And it was interesting. And so obviously that was the most challenging for many of us, to be able to share our weaknesses, because it's easy to share your strengths, but it's a little bit more difficult to share your weaknesses. To be able to say, you know, you've got this project, well, I can't do it, or I can't complete it, or I don't have the skill sets to do this. Again, effective communication and being vulnerable. So that was the challenge. But that was also the thing that was the most interesting and the most rewarding, when we were able to get that level of trust where people felt comfortable enough to share open and honest. And sort of, we had this, someone described it as this bubble that we had built with what we now call our first team. And we say we have to be true to our first team. So there are lots of teams in our organization, as I described, and our first team is that layer of chiefs and directors. And to them, we must be true. And when we got to a place where people felt comfortable to share, sometimes real sensitive information, vulnerable, be really vulnerable, that was amazing. That was almost a little tearful for me, that we had gotten to a point where people felt that comfortable.
Great. One last question for you, and I'm going to try my best to pose this appropriately. Yeah. From Judy Miller. She's asking, has this dramatically affected your employee retention? And I'm assuming that this means your approach to team cohesion. And her question is, are you doing new employee orientations differently due to your team cohesion work?
Yes, and so I believe it has. We've seen some of our lowest attrition in the last 3 years as we keep track of that, particularly, again, amongst our senior directors and our leaders. And then the other part to your question was, what's the other part to your question?
It was, are you doing new employee orientation?
Oh, yes. Mm-hmm. Yes, and so we do. As I said, we do a very specific joy in the workplace orientation with our senior leaders, our chiefs directors, and then we do talk about team cohesion and team engagement and how important that is to the organization during our general orientation.
Wonderful. Thank you guys again, Dr. Alli and Molly, for a wonderful, informative session. And I will speak personally as a former nonprofit healthcare CEO of a hospice organization during the pandemic. I certainly understand how leadership and cohesion is very important, certainly, during and also thinking about how you recover your workforce. So leadership visibility is critically important. So again, thank you to Dr. Alli and thank you to Molly Evans for your very informative presentations. I am going